Welcome to the Mad in America podcast, your source for science, psychiatry, and social justice.
Hello, everyone, and welcome to Mad in America. This is your host for today, Ayurti Dhar. I am an assistant professor of psychology at the University of West Georgia and a spotlight interviewer for Mad in America. Now, anyone who's heard my interviews will probably know that I've been growing interested in the topic of industry corruption, especially in the side disciplines and weirdly enough in emergency medicine. But for that matter, I'm actually teaching a course in research explorations right now. So I'm really excited about our guest today, Dr. Erick Turner, Associate Professor in the Department of Psychiatry at the Oregon Health and Science University. He's also a senior scholar with OHSU's Center for Ethics in Healthcare. Dr. Turner has been an FDA reviewer and has dedicated his work and life to improving research transparency. He is especially known for his 2008 paper on publication bias in antidepressant trials. And we will talk about that and a lot more and his newer review, which was published just last year, I think. Dr. Turner, welcome to Mad in America.
Thanks very much. Thanks for having me.
All right. So before we jump into your research, let me give our listeners and readers a little context and background. So let's go back a few years, right? In 2008, you, along with others, conducted a review of antidepressant trials to check for publication bias. Now, clinicians, researchers, and of course, most importantly, patients, service users, they need drug trials that accurately and truthfully tell them whether a drug works and also whether it has many adverse effects, like the question of efficacy and safety. In your initial review, you found massive problems in the way antidepressant trials were published or not published. So before we come to the newer work, could you tell us very quickly about what is publication bias? And we will get into it later, the different types, but just like a quick understanding of what is publication bias for our listeners.
Well, I guess to put it in simplest terms I can think of, just a picking and choosing as to what gets published and how it gets published.
And picking and choosing by authors and who are doing the trials and by journals.
Yes, both. It takes two to tango.
Right, absolutely. So in your older review, tell us what did you find and how did you actually conduct this research? What was the process?
Well, as far as the process goes, we used FDA review documents, and the FDA puts up its so-called drug approval packages when they approve a drug, and you can see all the results of all the trials that were done, which is not necessarily, which may or may not be published, which is the essence of publication bias. So we took a cohort of antidepressant trials for 12 drugs. We tracked them into the published literature to see whether each trial was published, and if so, how was it published? And so was it published in a way that agreed with the FDA or not? And so for 12 drugs, there were 74 clinical trials. And we found that contrary to what you would gather from the published literature, if you only looked at the output of what wound up in the published literature, you would have the impression that virtually all the trials were positive, and that the drug always, and by positive we mean that it was the drug demonstrated a statistical superiority to the placebo treatment arm. So it looked like the drugs couldn't fail. However, if you look at the FDA review documents, you found out there were quite a few more trials that you didn't even know existed from looking at the published literature. And furthermore, that the results, the way the results panned out, was 50-50 in terms of positive versus not positive. So 50% of the trials were the drug wasn't good enough to beat placebo. But you would never have known it from the published literature.
So apart from, for example, not publishing work that shows that the drug and the placebo, they're not statistically, different, or there is no significance to this thing. Apart from just not publishing, what were the other things that you noticed? Like, I think you wrote about the results were spinned very often.
Yeah, a number of the trials were spun. Probably the most common maneuver, if you will, was simply not publishing the trial, but it was also not at all uncommon to see. There were 11 trials, in fact, that were negative and drug did not beat placebo, yet that were published and looked positive. And so what they had done is use different, statistical alchemy, if you will, to make a silk purse out of a sow's ear. How about that? Yet another phrase, putting lipstick on a pig. Sometimes in giving talks, I've talked about my 11 pigs with lipstick. And then the colors of lipstick, and what was the color of lipstick in this case and that case, and how is this achieved?
Thank you. So since you're talking about giving talks and talking about putting lipstick on pigs, let me ask you, what was the response of the academic and the psychiatric community when this paper came out? Like, what were you expecting? What was your response when you saw all of this problematic, research and publication bias?
Well, I have to say that I wasn't shocked, because my background was I had worked at the FDA. And so I already had a sneak preview into this phenomenon and realized that there was this disconnect between what clinicians were seeing and what the FDA reviewers were saying, and what was known to the FDA and the pharmaceutical industry. So they had this sort of little secret going on that the doctors and patients out there weren't privy to. So anyway, yes, I wasn't shocked. I didn't know how the numbers would stack up, obviously, without doing the study, but I knew it wasn't going to be pretty.
What about others? Like I said, the academic and medical and psychiatric community, when the paper came out, was there any pushback? How did people respond?
Yeah, there were some. I would say that the drug companies, they hoped that it would blow over and it would be, and no one would notice. But there were two problems with that strategy. One was that the paper was published in the New England Journal of Medicine, which in turn gets a lot of attention by the press. In other words, the big names in media are generally going to look at all the journal articles published in a given issue. So it was noticed, and then the press, once the press got hold of it, it got international attention, and the major media markets, the major media in the U.S. and also in other parts of the world as well. So they couldn't ignore it because it was creating a bit of a stir, and so there were a few companies that broke the silence and decided to speak up and try to push back. And so one of the arguments was that the negative studies were really not so important after all. So that they didn't deserve to be published. And because sometimes when a drug doesn't beat placebo and there's another treatment arm in there, such as a drug that's already been approved, I don't want to get too much in the weeds on this, but they have made the argument, and I think it's a poor argument or a specious argument, that the drug, that the trial, quote, failed. And it's not that the drug failed, but rather the study failed. So their argument was that it shouldn't matter that the study wasn't published, because the study really was sort of scientifically flawed in retrospect. So we replied back to that letter to the editor that they had written to the New England Journal and said, well, why not let the academic community make that decision? Why not publish it and then let them decide, rather than paternalistically deprive them of the information in the first place?
Okay, that's 2008. We come to the more recent meta-analysis, and you used FDA reviews of, I think, 4 recent antidepressants and studied around 30 trials, right? 15 trials had negative and 15 positive outcomes, if I'm not wrong. But so this new review, right? You are doing this again. How have things changed since 2008? What did you find?
Well, much smaller sample size of a number of drugs, 4 drugs as opposed to 12 that we had in the earlier review. So the pace of new antidepressants come on the market has slowed from the good old days or bad old days, depending on your point of view. And so a smaller number of trials that were conducted. With that caveat that we're dealing with a smaller data set, we could still see that what was refreshing, in fact, is that there was improvement. Bottom line, there's going to be a bit of a glass half full, glass half empty aspect to this. So there were some negative trials that were published, and shockingly, they frankly admitted that there were negative trials. So that occurred in a few cases. Now, there were still some of the bad old habits of deep sixing, some of the negative trial. That also happened for sure. And also there was some spin that went on in a few cases as well. So that the old tricks are still in the playbook, but it's refreshing to see a little bit of movement towards improvement. So to put numbers on it, we found that the number of negative trials that were published transparently, that where they A, published them, period, and B, admitted that they were negative, that had gone up from the older cohort of trials from the earlier study was 11%, not many trials, but it went up to 47%, so a little shy of half. So that was better. Now, the positive trials, well, that's kind of a non-story because, well, of course, they're going to be published transparently.
So, moving on to your 2013 paper on publication bias in psychiatry. So you write that publication bias is prevalent in psychiatry, in medicine, even in other sciences. But you say it is especially awful and especially rampant in psychiatry. And my question is, what makes psychiatry so uniquely vulnerable to this?
It's hard to compare the disciplines. I think I don't want to let the other disciplines off the hook. I think it's easy to bash on psychiatry and psychology but I think that's the old joke about the street lamp, and a person's looking for his keys and he's looking under a street lamp, and someone wanders by and says, "What are you doing?" He says, "I'm looking for my keys." And so, where do you think you dropped them? I think I dropped them about 20 feet away. And so, why are you looking here? Well, this is where the light is. So in mental health and psychiatry and psychology, for whatever reason, most of the attention has been, scrutiny has been in that area. And so, we shouldn't, I don't think we really know just how bad it is in other areas unless we take a similar look and look at FDA reviews and compare, or some other way of getting at what has been called an inception cohort, looking at all the trials that were initiated and then track them into the published literature.
So the reason I ask is that I think at some point in your paper you do write, and I could be wrong, so I'll take a look at it again, but you do write that psychiatry has at least had a lot more of this, at least maybe because we've studied it more, like you're saying, right? So that's why I was wondering, is there something about mental health or the discipline that it makes it vulnerable to these things? Is there more vagueness or more, I don't know. I mean, the bigger philosophical questions of what are we studying and things like that?
In comparing different areas within psychiatry, there are some differences, and there's more of the publication bias. Well, let's put it that looking at antipsychotics, there was also publication bias, but there was less of it. But I think the reason for that is that there were fewer negative studies. So if we can go back to something I mentioned before about the distinction between, it's not so interesting to look at positive studies because, of course, they're going to be, if they're positive, of course, they're going to be published transparently. There's no need for publication bias. There's nothing to lie about. Put it bluntly, it's with the negative studies. So as you look at different drug classes within psychiatry, I think there's more of a temptation and a need for publication bias when the studies, the more negative studies you have in that area. So in antipsychotics, you had a smaller proportion of negative studies compared to antidepressants, and hence less of the public. You still had a fair amount, mind you. And then to step outside of into other areas of clinical medicine, if you have something that just a drug that just works hands down, and there's only, let's say that 95% of the trials are positive and only 5% of the trials are negative, well, at most, you're going to get a 5% rate of publication bias right there. So basically, it comes down to it's a manifestation of how effective the drugs are. So the more effective the drug, the less need for publication bias. The less effective the drug, the more the need for publication bias. And you can go, well, why is a certain class more prone to that? Why is a certain class of drugs less effective? Or why does it, maybe to put it another way, why does it have more trouble separating itself from placebo? And that could be that we're dealing with soft endpoints. For instance, we're dealing with subjective, we're asking questions, how do you rate your level of depression today? How is your depressed mood? How is your energy level? How did you sleep last night? All those things come down to the patient telling you or telling the investigator, reporting subjectively, whereas with, say, blood pressure, you've got a hard endpoint there. Or if you're looking at cholesterol, there's very little subjectivity, or I don't think there's any subjectivity in your cholesterol level. It's hard to get a placebo effect if you're looking at that. There's another kind of a topic here that we haven't really touched on, the publication bias. What is the motivation for it? So one is a lack of efficacy, but the other issue is safety. If there's a safety problem. So it could be that the drug works perfectly well, it does what it's supposed to do, but it's not supposed to kill people.
Let me then get kind of deeper into this paper. Could you tell us briefly about a couple of different types of biases, right? What are some of the other ways this is done?
Well, there's, so we talked about non-publication, just simply deep six the trial, and various kinds of spin. You mentioned the delay. One can, do statistical alchemy of various sorts. The most common method that we found in the earlier paper was to change the way that the dropouts were, because people drop out of clinical trials. Always. You start with a certain number. Let's say if you start with 100 patients, 50 get randomized to drug, 50 get randomized to placebo. I can guarantee you're never going to get 50. If you have an 8-week trial, you're not going to get 50 people in each group making it to the very. People are going to drop out. But the question becomes, what do you do with the data from the people who drop out? Because people who carry on and do, make it to the bitter end, they might be people that did particularly well on the drug, for instance. And if they drop out, maybe it's, the people who had side effects more, or they had less efficacy. So, the most common statistical maneuver, if you will, was to simply ignore the people that dropped out. You're not supposed to ignore these people. You're supposed to account for them statistically.
All right. So let's talk about blame, right? You write that blame for publication bias is complicated and it doesn't just lie in one simple small place, and that there are many parties involved. So I want to kind of get a little bit deeper into how do authors and journals and pharmaceuticals or medical device industry, right? How do they contribute? In other words, what does it look like on ground, right? Let's say an author conducts a study or a journal receives something. How is it done, really?
Well, I think you had you talked about a colleague who was had been disillusioned by the what I'll call the game playing of analyzing, reanalyzing, and I saw some of this myself with before I went to the FDA. It was like you finished up a study and there was this excitement about you get in the data and you've been working at this maybe for a year or longer. And you wonder, well, how, drum roll, how is this all going to turn out? So you start, crunching the numbers and everyone's all excited and then say, oh, shoot, the p-value is not statistically significant. It's not under 0.05. It's 0.08. Gosh, something must be wrong. And what did we do? And then you say, well, how about if we look at blah, 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 use this change this thing about do the analysis a little bit differently. And then someone says, well, I'm going to try this over here. And then bingo, P less than 0.05 over here. Oh, cool. It's sort of like a game. And I think people kind of geek out on it and take pride in being able to massage it into a statistically significant finding. But I want to maybe emphasize that I think the culture is such that we didn't think that we were doing anything wrong. We just thought this is the way it's done. And in so many, I think in many universities and elsewhere, that's kind of the way the culture has been, that you see your superiors, the people who have mentored you, and they're doing it that way. You think, well, I guess that's the way I'm supposed to do it too. And then you feel like if you get a non-significant finding, that somehow you have failed. People become attached to their sort of pet ideas as to what, this is what I just. In fact, they embarked on this whole study idea because they really believe that this works and this is going to help people. And then if you've worked at this for a year or 2 years or 5 years, and suddenly you've been going for 5 years believing that you've got something that really is going to make a difference and really truly works. And then comes a day when you crunch the numbers and bam, it doesn't work. It just creates this cognitive dissonance. Oh no, and those can't be. No, say it ain't so. It's sort of like Elizabeth Kubler-Ross's stages of grief. Denial is the first thing. No, it can't be. And then there's bargaining.
I think that's right. Yes. Then there's anger. I can definitely see that. No. Okay.
Right.
That's a fun way to put it.
And then you send it to the journal, and I've heard of stories where people will send, something that's, a negative study to a journal, and they won't even review it. They'll do a desk reject and say, this is of no interest to our, clinicians who read our journal. Or if it does get reviewed, they might get feedback from reviewers to say, oh man, why don't you try this other analysis there? Why not milking out a statistically significant finding, making the silk purse out of the sow's ear, or putting lipstick on the pig?
Exactly. So again, like you're saying, the blame lies with multiple parties out here. But I do want to note this. So this is a little more personal. What made you study this? What made you want to study antidepressant trials and publication bias? Was it a purely academic pursuit? I mean, you said you saw things at the FDA. Or was there also kind of a personal interest in this?
Yeah, as I mentioned earlier that I used to work as an FDA reviewer. And at the same time, there was another hat that I wore outside and outside the FDA, and that was as I had a private practice on the side. So many of my colleagues at the FDA probably most of them did not have a private practice, and so didn't have didn't identify with clinicians as much. So being in that role, I was kind of wearing both hats, and so I guess having been at NIH, having done research there, and then also having the private practice, I thought, well, I should, what's in journal articles is the truth. This is it. And, here we have access at NIH, we have access to, we're the bee's knees, I think is the old saying. Anyway, going from NIMH to FDA, I realized I really didn't know. I was humbled. I found out that we really didn't know diddly, shall we say, back at NIH. And so I saw these negative trials, and I thought it was something ethically wrong. What's wrong with this picture? There's at the FDA, I'm aware of all these negative trials, and that there's all this information about drugs that the FDA knows and that the pharmaceutical company knows, but doctors who are prescribing do not know. And I was reminded of that when putting on my hat. And then my clinician hat. It just seemed wrong that I should have to be operating on this incomplete data. And then later, upon coming to out to Oregon and interacting with clinicians, there were a couple of studies. I was trying to get approved by the IRB, and was some of them were placebo-controlled trials, and we were told that you can just forget about it. We're not going to approve any placebo-controlled trials, and the reason for that was that they believed that you could, if you had a new antidepressant, say, I'm just use antidepressant as an example, if you show that it works equally to an already approved antidepressant, say Prozac or Zoloft, then by transitivity, it must work too. So you just put up against Prozac or Zoloft or Paxil or whatever, and quote, we know, in quotes, we know those work. And so if you show that your new drug performs equally well, then it must work too. And I'd say, then I would say, well, wait a minute, Prozac, Zoloft, and Paxil don't always work. You say that you know they work, but they often don't beat placebo themselves. And they just sort of rolled their eyes and said, what are you talking about? The journal articles show that they work. And then I realized that, well, of course they believe this, because they believe, and they've been taught, like we've all been taught in medicine, that journal articles are the holy grail, and that's the truth with a capital T. And so it made me realize that at some point, no one's going to take my word for it, that there are all these negative studies. I have to prove it to them, and to prove it to them, I got to get something published here.
And I'm glad you did. So you talked about this. So I'm going to actually ask this question right now then. You talked about wearing this hat as a practicing psychiatrist, as a clinician. So I want to know, how do you work with this knowledge about inflated efficacy in your practice? And in other words, how do you deal with patients on a day-to-day basis, knowing what you know? What does it look like when you have this knowledge and you're a psychiatrist and you're working with patients?
I try to be transparent with them and let them know that, not to get their hopes up too much, that there is a chance that they may have a wonderful response, particularly if they've never had an antidepressant before. But the more trials they've had of antidepressants that haven't worked out, the less likely it is that the next one's going to work out. And let them know that, so these drugs work very well for some people, but there's a lot of people for whom they don't work at all. And there's a lot of people in between that where you get a partial response. And, you might have to try something else.
And I'm guessing it gets even more complicated with all the new research on tapering and withdrawal and antidepressant withdrawal, but, which we thought was apparently short-lived and mild, but turns out is not. So is that also information that that you share with patients and things like that?
We talk about that as well. And particularly that will vary according to which drug we're talking about, and some being more prone to withdrawal effects than others. And in some cases, I'll say, now, this is a drug you do not want to run out of,
Can I know which one that is, just in case?
Well, there's a couple of them. It's more than one, but I was thinking of duloxetine. Yeah, the couple of SNRIs, duloxetine and venlafaxine, brand name Effexor, those are a couple, but Paxil's SSRI these are all drugs that have short half-lives. So the blood level will will plummet if soon after you take the drug, it rises up, and then your body starts processing and getting rid of it. And some drugs your body gets rid of rather quickly, and in those cases you're more prone to withdrawal effects. So you don't want to miss a dose of those.
Thank you for sharing that. And we've been talking about drugs, but turns out that the problem is not just antidepressants or antipsychotics or psychopharmaceuticals. You also found that the problem lies with psychological treatments, the problem of publication bias, which makes it seem like it works a lot more than, let's say, it might actually, right? It inflates efficacy, in other words. Um, can you tell us a little bit about this research work of yours around therapy and psychological treatment, and again, publication bias in that?
Yeah, this in this study, we I think the key was to, in my opinion, it's best if you get what's called an inception cohort. I'll use that sort of a technical term, but that's to get evidence of the trial before the study is conducted. Because before a study is conducted, everyone believes that it will be positive. There's a high rate of optimism at that point, and then it's only when they break the blind and they crunch the numbers and it didn't. Then they're crestfallen. It's not everything they've been hoping for all those years is turning out to be, all those hopes have been dashed and they're disappointed and so on. But at the beginning of the trial, at the inception of the study, then everyone's optimistic. And that's what we did with the FDA. You basically have an inception cohort because the FDA learns about these studies, these clinical trials of drugs before they're done. Now, in the case of psychological studies for psychotherapy, there is no FDA. There's no such regulatory authority. However, we were able to use the grant evidence of grants, grant funding. So there's an NIH database called Reporter that we were able to generate identify a cohort of psychotherapy trials for depression that were conducted, and we could, as we had done with the FDA stuff for drugs, we could track these studies and see which ones were published. And we found that there were a number of those psychotherapy trials that had not been published. Yeah, we found that about 3/4 of the studies were published, which sounds pretty good, and that 23%, or roughly a quarter, were not published. So that's a fair, about a quarter of the trials not being published. There was a tiny proportion that simply weren't started, but all the other ones were completed. The vast majority of them were. So one limitation of that study is that we're simply dealing. All we could look at was the fact of publication versus not publication, and what we couldn't find out was about spin. Whereas we could, with the drugs, and look at FDA, you could say, okay, the FDA got this result, non-significant, but somehow they're coming up with a statistically significant result in the publication. We could not do that with these psychotherapy trials. So I think our results were actually paint a rosier picture, or it should be a worse picture than what we were showing, because surely there's some of those trials that were not all the ones that were published exactly the way they should have been.
So you saying that just reminded me, because I'd read about this, and this is, I think, a 2020 study where it happened in Germany. Am I right? Yeah. Marlene Stoll led the research, University of Medical Center Mainz in Germany, and they actually did find a bunch of spin in the results of specifically psychotherapy. So we have seen that, publication bias in drug trials, publication bias in psychotherapy trials, and even your other work that showed that even meta-analyses, often they're not perfect. They often don't report conflicts of interest that are there in the studies that they're studying. All of this together, let's come down to the real world effects of this, right? What are the real world consequences of publication bias? Of clinicians and researchers thinking that something works when it doesn't? I mean, what are the effects for patients, and what are the real world effects of this? That's it.
Well, there will be, we just touched on it briefly. There are the two major domains of the way to think about drugs, or any intervention for that matter, is efficacy, does it work, and safety. are there harms? So there's this in the clinical world, the clinicians talk about the risk-benefit ratio before they prescribe, and we'll discuss. We talked a few minutes ago about side effects and disclosing that with the patient. You say, okay, here's what you can expect from an efficacy standpoint if it works. How likely is it'll work, but also what are the potential downsides and what are the odds of that? So the problem, one of the problems with what publication bias will do, it will tend to exaggerate the benefits and downplay the harms. So you wind up with this perceived risk-benefit ratio that is overly rosy. And so that is what's going to get communicated to clinicians that are prescribing the drugs, and then gets then relayed on to the patients. So you wind up with more prescribing than is warranted, or a lack of vigilance for harms and slash side effects.
So, when you were doing all of this work, did you ever just meet clinicians who just didn't believe the work that you were doing? I'm wondering, how does this affect clinicians, right? So we just talked about how this affects patients, but what are clinicians doing when they find out about the kind of research that you have done? What is their response? How does it affect them in their practice?
I'd say this general area of research falls under the umbrella of meta research, or research about research, and I worry that a lot of clinicians don't know about it. In fact, I'm not sure there are a lot of researchers. Once you get out of the area of meta research, talk to some people, and they might go, "Huh? What are you talking about?" I think there's less of that, and you either get a "huh," like I didn't know that was happening, or you get, "Oh yeah, of course that happens," and everyone knows about that. But I don't know if if it translates into kind of critical thinking when it comes to consuming information. I think at least in the U.S., we've got these commercials on TV, and in the case of drugs, we got direct-to-consumer advertising, and you kind of you just know that if soap is advertised on TV and they tell you it's the best ever, you kind of roll your eyes and say, well, of course they would say that. They're trying to sell soap. But then when you see a drug ad, or you go to a conference and you hear someone, a key opinion leader, abbreviated KOL, talking about some drug, there's probably not enough of critical thinking. Well, wait a minute, this guy's funded, paid for to come here by such and such a drug company. So maybe that's why he's saying such wonderful things about this drug. Maybe I shouldn't be so quick to prescribe it. So somehow people put drugs and healthcare in general on a pedestal. It's like, but there are incentives and motives that go on that we don't hesitate to question are occurring in the real world. I mean, in the outside world, outside of healthcare. But when it comes to healthcare, they wouldn't. It must, if it's in a journal article, it must be true. It's peer reviewed. And so there's this naivete about healthcare in general, and about something being a peer reviewed journal, that it has somehow been blessed and sanctified and is not to be questioned.
So tell us about, since we're talking about this, right? And this was my training too in undergrad and master's. It wasn't until I reached my PhD work that the questions of, critiquing what peer-reviewed is, where does money come from, how is research conducted, and all of those questions came up. Can you tell us a little bit about the flaws that you see in the way peer-reviewed research is done?
I think that the biggest flaw comes in this, and it comes back to this issue of timing. And I talked about the importance in doing this kind of research is identifying an inception cohort. And why is that important? That's important because at study inception, before the study is done, everyone's optimistic and everyone believes that they're going to have positive results. The writing up of the manuscript occurs at a much later time point. So the study has been initiated, the data has been collected, all the analyses have been run and rerun until a statistically significant effect has been found, and then the writing starts. Okay, now we have something that's, quote, publishable, which is a real problematic word. The belief that you can't publish it unless it's statistically significant, and then it gets submitted to a journal. So the writing and the reviewing and the publication decisions are made at a point that follows the after you know the results. It's knowledge of the results that's critical. And if you can eliminate knowledge of the results as being a deciding factor as to whether it gets published or not, that, in my opinion, is I don't know if the one and only key, but it's probably the biggest key in my opinion.
So, correct me if I'm wrong, because my knowledge around this might not be great, but trials need to be registered, right? But just because trials are registered right at the beginning doesn't mean they have to be published. That's the big thing. What do you think would happen if we just forced trials to be published? Do you think that would be one way? Like, it doesn't matter if you're registered, you have to at least publish your results?
It depends on what you mean by published. If you mean published in a journal article, true, they do not have to be published, but the results do, by law, have to be posted on the clinicaltrials.gov. So I don't think many clinicians have thought about going to clinicaltrials.gov, for instance, and looking for results of clinical trials. They know about journal articles. They all know about journal articles, but have they ever thought of looking at clinicaltrials.gov? It doesn't tell you a story the way it doesn't have the storytelling panache that a journal article does. Now, the other approach that I wanted to touch on, though, there is one that reviewing is done in two stages. Once before the study is even conducted, and then later there's a stage 2 review. A stage 2 review done after the results are in, but the publication decision is made before the study is conducted. I mean, the peer review takes place at stage 1 and stage 2, and a decision is made as to whether it should be published at stage 1 before the study is done, and that's called registered reports. And that is an effort that's led by a psychologist at Cardiff University in Wales.
So in the first stage, then I'm guessing you basically look at the design and the method and everything, and you decide whether it's worthy of publication based on that and not the results, right? Okay, got it. Okay.
Yes. And to me, I think that's where the decision should be made, because you're making all the decisions. Okay, we're going to use, this is how many patients we want to recruit. This is, these are the methods that we're going to use. We're going to use these statistical tests. All those decisions can be made and are generally made. They are always made up front anyway. And in the case of grants, funding agencies decide whether to fund something based upon a protocol as well. So there's no reason that a publication decision can't be made then. So right there you can determine, is this good science? Are the methods good? The decision as to whether it's good science shouldn't depend upon whether the results turned out to be statistically significant or not.
This has been great. Thank you so much. The examples, and I learned things that deeply horrified me, but it was very enjoyable, as those two things go together sometimes.
Thanks very much. Thanks for having me.
Thank you for listening to the Mad in America podcast. Visit madinamerica.com for more news, views, and updates.